Hello, everyone, and thank you for joining us for the first event in our three-part series, Nurturing the Three Sisters, Community, Culture, Connection, and Urban Indian HIV Care. The longstanding Indigenous practice of companion planting the three sister crops of corn, beans, and squash allows them to all grow strong together. So too does Urban Indian HIV Care thrive with culturally grounded practices that foster connections between us all. Today, we launched the series with a discussion on harm reduction titled Rooted in Resilience, Urban Indian Harm Reduction for HIV Prevention. My name is Kayla Emmerich, and I'm a Public Health Program Associate with the Technical Assistance and Research Center, also known as TARC, at NCUIH. Joining me from the NCUIH team are Margot Balowitz, Public Health Associate, and Rachel Dio, Communications Associate. We are honored to have you all here today. We kindly ask that you place your name, organization, tribal affiliation, and title into the chat box. In addition, we welcome any feedback you'd like to provide about your webinar experience in our survey, which is also posted in the chat box. Next slide, please. And next slide, please. Perfect. I would like to bring your attention to a brief disclaimer that this event is made possible by the Minority HIV/AIDS Fund through the Indian Health Service. Additionally, we'd like to alert you to the fact that this presentation contains some sensitive subject matter, including discussions of injection drug use and images of needles. This is a reminder to please take some space for yourself as needed. Please feel free to engage with our program today, however is most comfortable for you. Next slide, please. As shown on our agenda, we will begin the session with an overview and some housekeeping, followed by an introduction to our wonderful presenter and the presentation. We will end the session with a Q&A and adjourn promptly at 3:00 p.m. Eastern Time. Next slide, please. For those of you that are unfamiliar with NCUIH, here's a little background. The National Council of Urban Indian Health, also known as NCUIH, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives, or AIANs, living in urban areas. NCUIH is the only national representative of the 41 Title V Urban Indian Organizations, or UIOs, under the Indian Health Service in the Indian Health Care Improvement Act, or IHCIA. NCUIH strives to improve the health of over 70% of the AIAN population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. As we dive into our session, here are a few things to keep in mind. This session is being recorded. All mics have been muted unless otherwise directed. Questions can be typed into the chat box, and a Q&A will follow at the end of the session. Please note the QR code at the bottom of the slide. Scan this with your phone to access our feedback survey. It's very much appreciated. Next slide, please. To ask a question, first select chat at the bottom of your Zoom screen, then type your question or comment into the chat box that will appear on the right of your screen. Next slide, please. I will now introduce our presenter for this session. Jessica Rienstra is a psychiatric mental health nurse practitioner at the Northwest Portland Area Indian Health Board, working as an ECHO case manager. She has worked across age populations in Washington state and internationally. During her time working at a tribal health center, she developed and implemented harm reduction, syringe service, and HCV elimination programs. She is passionate about ensuring accessible, destigmatized, and intentional healthcare for all. Next slide, please. Before we begin our presentation, we are going to pop up our first knowledge check, just a few quick questions for you to answer for us. Please select your answers for the following questions in the pop-up box on your screen. All right, we can go ahead and close the poll. Excellent. Thank you so much for your wonderful answers there. We will begin today's event by asking you to reflect on your current understanding of harm reduction. So we're going to go ahead and share a Mentimeter screen. If you haven't used Mentimeter before, it's going to be very straightforward, I promise. So Rachel's going to go ahead and share our presentation here. Following the instructions shown on the screen here, going to menti.com and entering that code at the top. This is an anonymous word cloud space for you to just share some thoughts on your perceptions of harm reduction. There's no wrong answers here, and this will just help us and our presenter get a sense of your background and your knowledge coming into this presentation with harm reduction. Meeting people where they are. Yeah, thank you for sharing that. And it's also completely fine if your perception is, I don't really know what harm reduction is yet. That's why I'm here today, to learn a little bit more. That's completely fine. Active listening, no judgment zone. Yeah. A lot of great reflections coming through. Compassion, safe practices. Yeah, these are some really great kind of keywords sharing just what those perceptions that were coming in with harm reduction are. We'll leave this up for just another minute. Open space here, self-determination. Absolutely. Education through self-determination. Sure. I really appreciate you all participating here. It's really, really helpful to just get this understanding of where people are coming in with what we've interacted with in terms of harm reduction before today. I'll give it a last 30 seconds here. Okay, well, thank you so much for participating here. We'll go back to our presentation. I always like starting with just that little bit of personal reflection and just kind of setting the scene for our presentation here. So we will now turn the floor over to Jessica Rienstra. Let us give a warm welcome by placing a heart emoji in the chat box or using a heart reaction.
Thank you so much, Kayla. And thank you so much, everyone, for being here. This is a topic that is really near and dear to my heart. And so I always am honored and excited to talk about harm reduction and then also to have discussion afterwards. It's definitely a symbiotic learning experience. It looks different in every community. And so I'm really grateful that you're all here taking the time for this discussion and talk today. My name is Jessica Rienstra. I am a nurse and just finished my degree for my psychiatric mental health nurse practitioner as well. And I work for the Northwest Portland Area Indian Health Board. And I work as one of the Indian Country Echo case managers. And as an Indian Country Echo case manager, we work to offer free services designed specifically to help ITU clinicians and administrators effectively care for patients with complex medical conditions. And to do this, we offer online echo clinics, in-person and virtual trainings, as well as TA and capacity building. And a big portion of my position is to focus on harm reduction. And so again, incredibly glad to be here and to continue advocating for health of patients and finding ways to offer these low barrier access points to care for those who utilize syringe service programs and harm reduction. I do want to make a brief disclaimer. These slides have kind of grown over the years and have had input from Dr. Jessica Gregg, Chief Medical Officer from DePaul Treatment Centers, from Nurse David Stevens at the Northwest Portland Area Indian Health Board, and then most importantly,
have really been molded and formed by my patients, individuals, and loved ones who have lived experience with syringe use and injection drug use. And I certainly would not be able to share this information without all of them teaching me so much with their expertise as well. So I want to honor them and the time that they've given and shared with me. Next slide, please. So we'll go through today and talk about some of it might seem kind of basic and some of it might be new, but I think really importantly, when we hear the word harm reduction, there's often a lot of emotion and a lot of thoughts about exactly what that is. And so I want to make sure we have like a unified view on harm reduction and kind of what that definition is and how it plays into the work that we do and the services we offer our communities. So we'll review at the beginning what harm reduction is and what it isn't. And then I want to discuss a couple of examples of why harm reduction matters and how it has been applied in settings already. Again, it'll look a little bit different community to community, state to state, in different geographical settings. And so I always enjoy hearing about the amazing work that different tribes are doing to offer services and the really innovative ways that they're meeting their community's needs. As somebody mentioned in the chat right out of the bat, that, yeah, harm reduction is meeting people where they're at. So I'm excited to talk more about that as well. I'll talk a little bit about the application of harm reduction in different settings. And then I'm really excited just to have some discussion as well and hear thoughts, comments, concerns, find ways to support the work that you all are doing as well. Next slide, please. So what is harm reduction? Harm reduction is something all of us do every day. I know over the years working as a nurse, harm reduction for some providers I worked with almost was like a dirty word, like, oh, harm reduction or syringes. But when we think about harm reduction, especially in a medical setting, it is something we offer patients and individuals in every type of chronic disease process. We're always looking at ways to minimize harms in our own lives as well. So even like day to day, if you go to next screen or next slide, please. Thank you. If it's really hot out, we'll put sunscreen on our kids. We'll put sunscreen on ourselves if we remember. Next slide. We buckle up for safety. We follow rules of the road most of the time. It's another day-to-day harm reduction effort that we do without thinking most of the time. Next slide. We mask up, especially depending on what level of COVID outbreak is in our area. We're taking these precautions and we're utilizing harms reduction in our everyday lives. Next slide. So harm reduction is this really broad topic that we already incorporate in all sorts of actions daily. And so what is it and how is it applied specifically with substance use disorders? Next slide. So it's a very practical set of strategies, and it's aimed at reducing the negative consequences associated with drug use. So it also is a movement for social justice built on a belief in respect for the rights of people who use substances. Really want to make sure that it is built by and for people who utilize substances and that we are honoring their lives and helping them be as safe as they possibly can. Next slide. And again, just highlighting the respect and belief in the rights for people who use drugs and alcohol. Next slide. I rarely meet somebody who has not been directly impacted by substance use, either a close friend, a loved one, immediate or distant relative, neighbor. And so people who use drugs and alcohol are people first. They are our neighbors, they are our friends, they are our brothers, our sisters, our relatives. They are part of our community and they are an equal part of our community. Next slide, please. And just another reminder that substance use doesn't negate the value of their lives. Having this chronic disease of a substance use disorder doesn't diminish how important they are as a person. Next slide. So what we can do first and foremost is to keep them safe, keep them alive, and to let them know that they are loved. And that for me is the root of harm reduction, that we are offering respect, kindness, love to our brothers, sisters, and community members, allowing them the same options for safety that we offer others, and keeping them alive. So depending on where they're at in the spectrum, maybe we would love to see them way onto one side where they're just not using any substances and they are completely in sobriety. And that's an okay goal for us to have, but if that's not where they want to be, we again have to meet them where they're at and find ways to keep them as safe as possible in the area that they are at this moment. Next slide, please. Harm reduction is definitely not an encouragement to utilize substances. It is not incompatible with other substance use disorder treatment. Oftentimes you'll see maybe like a opioid treatment program or medication assisted therapy, and they won't have harm reduction as part of their program. And to me, that's a bit counterintuitive because harm reduction aligns with all of these other programs. It is a part, again, it's on that spectrum of recovery. And harm reduction is not giving up. In fact, it's leaning in, it's caring more. Next slide, please. So we'll go into discussing examples of why harm reduction matters and how it has been applied. And again, just a reminder, there are some images of syringes throughout this presentation. And I know that this topic can be incredibly emotive. It is for me as well. And so, as Kayla mentioned, please take space as you need it. Next slide, please. So first example of harm reduction would be a syringe service program. And syringe service programs, often called SSPs or a needle exchange, they distribute sterile syringes, offer safer drug use supplies, and then also education to people who inject drugs, as well as creating relationships. And so oftentimes in the past, patients that I would see accessing a syringe service program were patients that hadn't been in to see their primary care doctor for years, even decades, because they didn't feel like they had a place at their health clinic. And so starting to rebuild those relationships to encourage trust and respect, and then being able to see patients accessing healthcare in ways that they deserve to access healthcare, because again, they are equal parts of our community. Next slide. So why would we start an SSP or a syringe service program? Next slide. We've seen increasingly escalating rates of addiction, and with that, transmittable diseases such as HIV, Hep C, and other infectious diseases associated with infection drug use are also on the rise. Next slide, please. So this information is not even as up to date as our current 2023, as we know it's even higher now. But from 2010 to 2016, HCV infection had a 3.5-fold increase, and the majority of these new infections were due to injection drug use. And over 25 new HIV infections occur each year. Again, projection is higher than that at this point among people who inject drugs. Next slide. So again, looking at related hospitalizations and overall percentage of hospitalizations. So we have serious bacterial infections, including soft skin tissue infections, osteomyelitis, endocarditis, and other particularly morbid and mortal consequences of injection drug use. And in Oregon, hospitalizations for injection drug use related serious bacterial infections increased dramatically and really had a substantial cost on the healthcare system from 2008 to 2018. And the increase in hospitalizations really represents an opportunity to initiate substance use disorder treatment and harm reduction services to improve outcomes for individuals who are utilizing substances. We know that STIs are on the rise, and safe sex supplies are a vital part of harm reduction programs. Routine screening is a key part of harm reduction programs. That includes pregnancy testing, low barrier access to treatment for STIs, and PrEP are also key parts of harm reduction programs. And this is just another area where we can begin to meet people where they're at and offer these services that they deserve in a way that they are able to access them and feel comfortable accessing them. Next slide, please. So again, back to the why of syringe service programs. And we look here at the overdose deaths in 12 months at the end of 2020, 81,000. And that's the highest number ever recorded in a 12-month period. A lot of this, as I'm sure you've seen in your communities, was increased by the increase in fentanyl that we see in the drug supply, and also a lot of increased isolation during and difficulty accessing care and supplies during the COVID pandemic. Next slide, please. Certain service programs are associated with a 50% reduction in HIV and HCV incidents. So even, for me, this is something that I feel passionate about from a humanitarian point of view, but even if you had to look at it just from a fiscal point of view, or if you are completely a numbers person and it has to fit the budget, there's a 50% reduction of HIV and HCV incidents that is associated with certain service programs. And when you also offer services like medication assisted therapies to treat opioid dependence, that transmission is reduced by over 2/3. So again, the HCV and HIV transmission reduced by 2/3 when there is access to a sterile syringe program, as well as medication assisted therapy for opioid use dependence. Next slide, please. The new users of certain service programs are 5 times more likely to enter treatment and 3 times more likely to stop using drugs than those who don't use the programs. So again, this is a way to offer support, to meet people where they are, and to have an open door if they want to go further in their recovery. So we're keeping them safe. We're letting them know they're loved. They're a vital part of our communities. And also here's an open door and easy access if and when you're ready to take the next step of recovery. Without certain service programs, we really miss the opportunity to reduce the harms associated with infectious diseases, including HIV, HCV, and serious bacterial infections. We miss the opportunity to provide life-saving access to naloxone and prevent accidental drug poisoning deaths, and it will increase the likelihood that people enter into treatment if they are interested. Next slide. So moving on to how, we kind of talked about the why. So how do SSPs do this? Next slide, please. They're not just about sharing needles or equipment, but if you look here at this micro view of the tip of a needle, needles are made for a one-time use. Your doctor's office doesn't bleach needles and then use the needle again on the next patient. Needles are a one-time use item. And even if one person is reusing their own sterile syringes, no longer sterile, but wouldn't be, transmitting diseases or sharing with others, after several uses, you can see here just 6 times, the tip of that needle is no longer in good shape and will absolutely give somebody an abscess or open skin, creating another pathway for infection. And so needles really need to be a single use for one person and one time. One needle, one person, one time. And new needles decrease infection in other ways as well. Next slide. So I know we focused a lot on the injection side of the sterile syringe program, but absolutely that is just a drop in the greater bucket of SSPs. They provide much more than just needles. Next slide. SSPs provide connection. Substance use disorder is an incredibly isolating, lonely, chronic disease. And being able to offer support to find points of contact with individuals struggling with substance use is really critical in offering as much support as we can for our community members struggling with substance use disorder. Next slide. When we look at the different effects colonization has had and leading to so much trauma, grief, loss, and stress, which are often underlying factors for addiction, to fight this, we look at the values of community and culture and tradition, friends and family, and how this can offer healing, joy, bonding, and peace, and create connection. And the best way that we can fight addiction is with connection. And having harm reduction programs is another way to offer connection with patients and individuals who are struggling with addiction. Next slide. Another service that SSPs can offer is fentanyl testing. Now, not every area may be dealing with the same amount of this. Also, some areas that I've worked in have had fentanyl in everything. And so they decided to stop offering fentanyl testing strips because it was present in meth, it was present in stimulants, it was present in opiates. And so it was kind of for them, just the assumption that fentanyl was present in any substance worked for that community. So again, it'll be very community specific, but I do just want to point out that fentanyl test strips look different than like a pregnancy test or COVID test. So 2 lines on a fentanyl test is negative for fentanyl, and 1 line is positive for fentanyl. So it's backwards from what we're used to seeing on test strips, but I do just want to make that note. Next slide. Also hugely important, syringe service programs provide Narcan, naloxone directly to patients who are utilizing substances. And this matters because people who use substances perform the majority of the report, like over 80% of reported overdose reversals. So they are in their friend group or their community group that are utilizing substances, and they are often the first responders to their friend and loved ones accidental overdose from substances. So they're the ones out there reversing these overdoses with naloxone. So ensuring that naloxone is being provided to family members, to anyone in the community who would like to have access to it is really, really key. So oftentimes I'll hear, you know, I don't know where to get started. We can't start an SFP right now. Should we even try? A great starting point just to start building those relationships is to start offering Narcan and naloxone and to create some of those relationships with people who could be utilizing that. Next slide. So I want to really highlight some of the incredible work that different communities are doing. The Siletz tribe has a harm reduction program where they received a HIV Early Intervention Services and Outreach Award from the Oregon Health Authority. And with all of the funding, they were able to offer a syringe exchange, distribute Narcan nasal spray, and offer rapid like point of care HIV and HCV testing, as well as connecting clients to medical services and social services. So they have a really incredible program there. Next slide. Example 2, we started with syringe service programs, and then now moving into another form of harm reduction would be utilizing medication to treat opioid use disorder. Next slide. So why would we utilize medication? You know, is this just switching out one substance for another? Is this causing a different dependence from one dependence to the next? These are some of the questions that I hear sometimes. Next slide. So when we look at methadone treatment and mortality risk, the graph showing mortality risk during and after methadone treatment, on the left, you can see all-cause mortality. On the right, it shows overdose mortality. And basically the gray is off methadone and the orange is on methadone. So you can see patients with opioid use disorder on methadone are much less likely to die from any cause. And on the right, there's this remarkable risk and decrease from dying from an accidental drug poisoning for patients on methadone versus not. So it's a stunningly effective medication. Again, it is just an option. It's not for everybody, but it's an option to be explored when we're thinking about harm reduction. We see similar effects for buprenorphine, or Suboxone as it's called sometimes, which is another medication for opioid use disorder. Both of these medications save lives. And again, that's one of kind of the keystones of harm reduction, is keeping our loved ones alive. It is stunning not only because of the decrease in the risk of dying, not just from overdose, it's from anything. It's less hepatitis C, less HIV, fewer infections in the heart, fewer car accidents, fewer people driving while impaired. So again, it is really, truly a life-saving medication. Next slide. So how can this be incorporated? Next slide, please. So I want to again highlight incredible work being done at Great Circle Recovery, which is down in Salem. And I think it's a great example of how to integrate and provide low barrier access to comprehensive care, including medications for opioid use disorder. And it's through tribally operated clinics and tribes exerting sovereignty to provide this care. And this is an example of the amazing Great Circle Recovery Program, the first tribal OTP in Oregon, opened by the Confederated Tribes of Grand Ronde, designed for Native and non-Native patients. And they have a clinic in both Salem and one opening soon in Portland. They have medications to treat opioid use disorder, offer individual counseling, group counseling, peer support services, lab draws, transportation, mobile treatment, and more. And in addition to opioid treatment programs, or OTPs, primary care clinics play a really important role in also providing services and medications for opioid use disorder. While methadone can't be given at an outpatient setting, like a primary care provider can't prescribe methadone. Buprenorphine, or again, sometimes called Suboxone, is something that primary care providers can prescribe patients in the outpatient setting, and again, saves lives. It's an incredibly effective medication and something that we can incorporate into primary care. Next slide. Telemedicine is also a great option to provide these medications. Federal agencies really eased the telemedicine restrictions during 2019 and during COVID-19. And these changes permitted clinicians to prescribe buprenorphine to patients with opioid use disorder without an in-person visit. And that really allowed a lower barrier access for a lot of patients who needed access to, again, this life-saving medication. We want to keep seeing these treatment options in lower threshold areas. Next slide. I won't go through this now, but this is a fantastic article that focuses on a few stories that really illustrates how policy changes for telemedicine for buprenorphine can really expand the availability of addiction services for patients with opioid use disorder who previously weren't able to engage, either because of geography, lack of housing, transportation difficulties, or just like really understandable mistrust of the traditional healthcare systems. Next slide. Okay, so we're going to head into considering the application of harm reduction in different settings. Next slide. So we'll take a look at the hospital setting, and substance use can be directly related to the reason for clinical appointments or hospital admission, but substance use disorders are generally not addressed or treated, and the use of drugs or alcohol while in the hospital is not allowed. And so this is kind of creating an unwelcome environment for patients suffering from substance use disorders who need to access clinical or hospital services. Next slide, please. So here's an example of a team that has taken the challenge kind of head on, and it's called the Improving Addiction Care Team, IMPACT, and it's a multidisciplinary team. They're treating substance use disorders through medication, behavioral health interventions, connecting to peers, and connecting patients to ongoing care after discharge, and has really created a change in terms of how individuals with substance use disorders are treated at OHSU. Next slide, please. And what about patients who don't want treatment and struggle to stop using drugs or alcohol in the hospital? Next slide. So sorry if you don't like Schitt's Creek, but like Moira Rose's hair, this is a complicated, a little messy, and a really interesting question. Next slide, please. So the goal is to improve care for patients, and it's been possible to continue to treat these patients by having this goal in mind. So improving care for patients with substance use disorders, whether or not the patient wants to decrease or stop their use. Next slide. So some ways that this can be seen and achieved with clinical and hospital-based interventions is, again, finding ways to offer and acknowledge drug and alcohol use in a non-stigmatizing way. Ensuring that medications such as methadone and buprenorphine are immediately available for those who want it, whether or not they plan to continue after discharge, just to ensure that cravings and withdrawal are being adequately addressed when the person is hospitalized or in clinic. Ensuring that there are peers there that have no agenda other than to offer support. So they're not there just to get somebody into treatment. They're not there just to kind of walk them through the next steps. They're just there to offer support. They're just there to help them navigate this really confusing system that was not set up to support them. So again, changing that, offering support. Creating care conferences, talking about like the patient's goals, making sure that the treatment of the disease that they're in the hospital for is being addressed, as well as the staff safety goals are all being taken into consideration. So there's really, the patient is part of this collaborative team of care. And then providing Narcan or naloxone on discharge if the patient leaves. Also providing these harm reduction or safer use kits on discharge if the patient leaves. So making sure that when they leave, you know, if they came in to be treated for endocarditis or for a disease that they were exposed to because of an unsafe injection, that they're being sent out with a harm reduction tools so that they're not re-exposed to that. So again, like improving their health, continuing to keep them safe, and continuing to show them that they're loved and keeping them alive. Next slide, please. So through this impact program, the results, they saw twofold greater odds of receiving STD treatment after discharge compared to similar patients who did not engage with impact. And then they also saw that there is probability that interaction with impact also decreased mortality of that patient group. Next slide, please. So how would this look in residential drug and alcohol treatment? Next slide. Where use is not allowed, and generally individuals seek residential treatment because use is not allowed. So they're going there because they're looking for a place of sobriety. And an individual's ongoing use, may harm others in the environment. Next slide. So again, like Moira's hair, it's complicated, it's a little messy, and it gets even more interesting. Next slide. So harm reduction in residential drug and alcohol treatment programs is definitely an iterative process. We're continuing to learn and grow as we find new ways to address this, but having rapid access to buprenorphine for any resident who needs it. So ensuring that we're not leaving somebody to suffer. They came for help with recovery, and then ensuring that that is a safe process for them that is as comfortable as possible for them. Definitely never easy, but we want to offer as many supports as we can. So offering rapid access to buprenorphine. Oh, thanks, Tiffany. And making sure that we're having these systems of care conferences. So we're not kicking somebody out immediately. There's not this reactive, like you broke a rule, so you're out of here. So talking about, what are the needs? Are we meeting this individual's needs? What are the resources that we can use to meet this individual's needs? And then framing struggles as treatment mismatch, not failure. Maybe this isn't the right setting. Maybe it's not the right time. This isn't a treatment failure, but finding the right time, really going through a lot of that motivational interviewing. Is this, are you ready? Is there a catalyst for change? Are you ready for change? Again, warm handoffs to the next level of care, whether that's higher care or stepping down in care. Making sure that there is, again, naloxone in everyone's hands on discharge, and then offering safer use kits. So again, I feel like residential treatment programs are often an area where harm reduction is maybe looked away from. And so embracing the idea that this is a spectrum and that patients deserve access to safety regardless of where they are at on that spectrum, and making sure that if a patient needs access to safer use kits, that they are there and they have them. Next slide, please. So summary here, harm reduction is an evidence-based set of practices and practical strategies that saves lives. Harm reduction can take several forms. Harm reduction can and should be applied in all treatment settings. And harm reduction really is rooted in a lot of cultural values of community care, sharing love for each other's sacred and beloved life, and making sure that we are honoring one another and respecting one another. We want people to know that their life is sacred and they're loved. And we want everybody who walks through the doors of our clinic, of our hospital, of our office, whatever setting we're in, we want them to, when we interact with them, we want them to know that they feel that way. And then this is regardless of their trajectory of sobriety. So whether or not they're ready for the next step, they're still valuable, they're still loved, they're still sacred. And that is something that I feel really strongly is one of these roots of harm reduction. Next slide, please. So again, a slide here about the intersection when we look at culture and tradition and harm reduction, and how they intersect with these ideas of compassion, relationships, inclusion, patience, positive communication, and again, as someone so thankfully said at the very beginning, meeting people where they're at. Next slide, please. So we offer through the board monthly harm reduction echo sessions, and they're a pretty interesting place to join to hear other people who are doing the work in a variety of settings, either on the ground or more administratively. And those are the first Tuesday of every month from 12 to 1 p.m. PT, and just provides comprehensive information for those implementing or interested in starting harm reduction programs to share best practices, sometimes troubleshooting some complex questions, discussing different policy issues, and continuing to ensure that our people are receiving the care that they need when they need it and in their own community. So if you're ever interested or available, please feel free to message me with your email address or reach out via email, and my email will be at the end here. So next slide. So questions, thoughts, concerns, and I think Kayla, if you go, or if we go one more slide, we'll have my email there. Perfect. And so again, I want to really say thank you for sharing this space with me. I'm excited to have some discussion here shortly. And just a reminder that each one of you are sacred and beloved, because when we hold that for ourselves, we can also give it freely to those that we serve. Thank you so much.
Thank you very much, Jessica, for that amazing and informative presentation. Please place an applause emoji in the chat box for Jessica. Before we begin our Q&A, we're going to pop up our final knowledge check for the day. So please select your answers in the following questions in the pop-up box. And we'll leave that up for about 30 seconds. Many thanks to Jessica for being here with us today. All right, we can go ahead and end the poll. All right, and as we begin our presenter Q&A today, we're going to ask you to once again reflect on your perceptions of harm reduction, just like we did at the beginning. Have they changed at all over the course of this presentation? And this is also going to be an anonymous space to share any questions you have about harm reduction. So please feel free to share here. Same instructions as the first time around, menti.com, and you've got the code on the top of the screen there. So again, this is an anonymous space. It's completely fine if you still have complicated or uncertain feelings about aspects of harm reduction. This is a great place to share those reflections and start spurring kind of the discussion that we want to have here. So feel free to add questions. Feel free to also just share a few thoughts that you're having. We had a lot of really wonderful thoughts shared at the beginning about meeting people where they are and being present with compassion. I'm always curious if things like that change or shift or get added to over the course of a presentation like this, and would love to kind of hear how those thoughts have shifted. Harm reduction is important and necessary. Absolutely. Yes. I think Jessica did a great job of laying out a lot of different scenarios where just those principles of harm reduction are going to have a big impact on the lives of the people that we care about. It's also fine if your perceptions haven't shifted much, if it's really just, oh, this is kind of confirming what I thought I already knew. I got a little bit more information, but you know, kind of those key points sort of getting hit home about what harm reduction really is and why it's so important. We can leave this up for just another minute. Feel free to think through any questions you might want to ask to Jessica as well. You can share them in our general meeting chat. And in just a moment, we'll welcome you to come off of mute and share your video and ask any questions you may have as well. All right, we can go ahead and go back to the presentation. And we can go into a more open Q&A. The floor is now open for any questions or comments you may have about today's presentation. So as I said, please feel free to turn on your cameras, come off of mute, or just place your questions in the chat box.
I'm not sure if I'm allowed to ask a question, Kayla, but
Sure.
I do have a question for people in attendance. Really curious to know how you see harm reduction practices currently being used in your communities right now. If you do have them, and what that kind of looks like where you're at, and or what do you think would work best where you're at?
That's a great question for our audience here. If you'd like to either come off of mute and address just what harm reduction services are looking like in your communities, or feel free to just share in the chat. That's also fine. It'd also be interesting to hear if there isn't much in the way of harm reduction programs. I think, Jessica addressed a few of the barriers or difficulties or places where harm reduction isn't quite utilized as much as it could be. So some reflection on, what some of those barriers and challenges might be as well is more than welcome. Molly says harm reduction in red states is a little political. Most services are nonprofit, non-government funded based. Absolutely. And Jancy shares, we have a coalition tracking overdoses, Narcan distribution, and leading education efforts. Our health department hosts a weekly SSP. Our organization offers harm reduction kits to program participants. That's fantastic. Yeah. Thank you for sharing that. And to Molly's point, I've seen a few locations where maybe folks are trying to start things like SSPs, and there's a lot of state or local pushback, whether it's in the laws or the particular organizations folks are working with. It can be really tricky to navigate that political side of things.
Absolutely. I think even in blue states, it can be really tricky to navigate in certain areas. So especially so in red states. And just as a note of encouragement, I know Dr. Jorge Mera in Cherokee was working for years and years on getting harm reduction up and running, and a lot of battles, a lot of policy work. And I think maybe 8 years later, but they have a harm reduction program in Tahlequah now. So I just did a little shout out for them and a link in the chat, but they're doing great work. And yeah, keep fighting. And if we can help fight with you, please email me. I'll do what I can.
Perfect. Liz also shared our state, New Hampshire, just launched a mobile harm reduction van, which is stocked with naloxone, fentanyl test strips, wound care kits, bottled water, COVID tests, and other items. It's a fantastic way. I'm talking about meeting people where they are, being able to go directly to literally where folks are. And Micah also shared, local to me, the South, a lot of people still have negative views around substance use, which makes getting support for harm reduction difficult, which I think we've seen in quite a few contexts.
Absolutely. And I think just having those conversations, continuing to discuss, because again, it's such an emotional topic. And I think even people who have very opposing views from me, usually it's due to a personal kind of emotional experience that they had, or a loss that they had. So I think creating space to continue to have those really difficult discussions, to keep talking with people, keep sharing why it is such an important way to show people that we love and care about them, and can really slowly move the meter. But I do understand what a struggle it is, for sure.
Absolutely. Thanks to everyone who's shared their experiences, or their what their community is either has implemented or is maybe seeing some barriers in the way. I think it really strikes home just how varied harm reduction might look from one place to the next, and how important it is to continue the conversation. Yeah, this is still an open discussion space. If folks have questions for our presenter, I'm sure Jessica would love to address. Maybe if you have particular challenges starting harm reduction in your organization, or getting buy-in from folks that you work with, that's absolutely something Jessica could speak to. Well, I think I'd like to put a question to you, Jessica, just since we're talking about those kind of difficulties around stigma with drug use in general. What are your recommendations for battling that stigma? How do you approach those conversations with folks who might have really negative perceptions of people who use substances?
Yeah, that's a great question. And I think the answer might be a little bit varied, but I think finding out maybe where they're coming from. So again, I think harm reduction is meeting people where they're at on both sides. So what, caused these really negative views, and it might just be, historical society telling people that this is how they should think about substance use. And so finding ways to connect with that person with opposing views can be helpful. Discussing just the facts, so taking emotion out of it and just the facts. Substance use disorder is a chronic disease. Here's medically how we treat chronic diseases. We offer harm reduction to people with heart issues. We offer harm reduction to patients with diabetes. And so for a patient with substance use disorder, they're just as deserving of appropriate healthcare as every other patient that we serve. And so finding ways, I guess, depending on where the person was coming from. So whether it was a coworker in a clinic or a community member, really giving space and listening to their concern, and then finding ways to kind of address their specific concern. And so, maybe they don't want more needles in the community, and so they think syringe service programs are bad because it'll be more needles. Well, most syringe service programs see a massive decrease in syringes and syringe litter in the community, because they're offering a safe place for people to dispose of their utilized syringes. Often they're offering different sharps containers. Sometimes they put community sharps containers out. And so harm reduction is really about community health. It's not just specifically for the person or individual who utilizes substances. It's again for the whole community. And so finding ways to humanize the individual, whatever way that might be, I guess, best addressed for that person who feels like it's just really, really stigmatizing, will look a little bit different person to person. But making it personal, I guess, as far as like, these are our aunties, our uncles, our brothers, our sisters, like they deserve care and love. And how, is your plan going to show them that? How is talk me through how your plan is going to get them to recovery? How is your plan going to get change happening? So it is, I would say, it is always uncomfortable and it's always difficult. And even in clinics where I've worked and have had like lots of positive change, staff often turns over, leadership turns over. So there's always, I will say, opportunity for more uncomfortable discussion and growth. And I learn a lot. And I think, yeah, just continuing to put people first. Like, this is a person. This isn't somebody, who's just out there using drugs or different, negative terms that people will use for people who utilize substances. This is a human that we're sharing the space with, sharing our community with. But I have some flyers that maybe I'll pop in the chat here in a minute, just about different language that you can use to destigmatize. And so let me grab those in a minute.
Yeah, that would be wonderful. Thank you for that. I think, like you've mentioned a few times, there can be so much emotion attached to this topic for folks. So really giving space for that conversation and kind of wading through what somebody's concerns are, and just getting to the humanity of everyone involved. I love the way that you speak about it.
Yeah, absolutely. Let me know if this link opens on your end.
It's opening for me, and we can absolutely include that in our post-event email out to all of our participants as well.
Fantastic. So for those who don't want to open it right now, it's just a one-pager about why words matter when we talk about addiction and why it's important to use healing words. And again, this is another evidence-based practice of, research has shown us that language matters when we talk about opioids. And when doctors use stigmatizing language, they're less likely to give good care to people who are suffering from addiction. There's just all this implicit bias and the unique ways that our brains work. And so finding ways, even things like saying, oh, the urine came back dirty or the urine came back clean. So just removing some of that like ethical and moral application to something as simple as this urine was positive for a substance, this urine was negative for a substance. It's not an ethical failing or a moral failing to have a chronic disease. And so really trying to take that language away from it and just using, again, person first language and language that isn't shaming or stigmatizing.
Yes, thank you for sharing that, Jessica. And we're getting right up to time, so we'll go ahead and wrap up for today. Next slide, please, Rachel. And thank you so much for joining us for this first session in our Nurturing the Three Sisters series. We also thank our presenter for this wonderful presentation. Please show your appreciation with the celebration reaction or celebration emoji in the chat box. We deeply appreciate any feedback you'd like to provide about your session experience. So please complete our session survey by using your phone to scan the QR code on the slide or by clicking the link that's placed in the chat box. Those who do complete the evaluation will have a chance to receive a mystery NCUIH swag item. So stay tuned for that if you fill it out. So thank you very much. Next slide, please. We have many upcoming events hosted by NCUIH that we would love for you all to join. So here's a comprehensive list. I'll highlight just a few. Our second session in the Nurturing the Three Sisters series is on April 12th. And that's titled Growing Strong Together, Creating Two-Spirit and LGBTQIA+ Inclusive Healthcare Services. I'd also like to highlight our event on April 26th, Standing Together to Address Urban Indian STI Disparities, Strengthening Syphilis Care in Indian Country. And finally, our third session in Nurturing Three Sisters series, Branching Out Wellness Programming for Patient-Centered HIV Care from an Urban Indian Perspective, and that will be on June 8th. Please visit ncuih.org/events for more information and registration links for all of our upcoming events. And that is all for today. Thank you again for attending. Have a wonderful rest of your day, everyone.